Good afternoon, everyone. My name is Nicole Fernandez. I'm the Maternal Infant Health Project Manager for Wayside Recovery Center. For those of you who may be joining us for the first time, Wayside Recovery Center began its mission to improve the quality of lives of women. We were one of the first agencies in the country to allow our women to bring their children into treatment. Since then, we've become an expert in delivering gender-specific and trauma-informed care around substance use disorder treatment and mental health services for women and their families. We provide a holistic array of care, including outpatient and residential substance use disorder treatment, recovery services, adult and children's mental health therapy, and long-term supportive housing and family support services. We also provide additional support and connection to our alumni, and we are in this maternal health space with a grant. We thank SAMHSA and Minnesota Department of Human Services has provided us with a state opioid response 2 grant in order to provide the Maternal Infant Health Project Echo series, as well as it supports our women's wellness series, in which previously we had Indigenous women's wellness and women's wellness. And so we appreciate you joining us today. We thank you for taking your time. We thank you for the recommendations of speakers. And as Angelica mentioned, she sees the diversity in our audience, and that's a credit to those of you who are even attending today. So we thank you. Without further ado, I would like to introduce you to our speaker today and the topic that we will be hearing on, which is reproductive grief care in the 4th trimester. We are hearing from Ms. Angelica Quezada, and Angelica is a bilingual licensed clinical social worker in California with a master's degree from the University of Southern California. As the director of the mental health programs at the Institute of Reproductive Grief Care, she promotes the Institute's mission in order to instill hope, change, understanding, and healing by developing accredited trainings, establishing mental health resources, and aiding in data collection and research. She has experience working in hospice, schools, hospitals, in home, nonprofit organizations, and private practice settings. Angelica is passionate about breaking mental health stigmas by providing compassionate education and psychotherapy utilizing evidence-based practices. She offers emotional and therapeutic support to individuals navigating all phases of life, including perinatal, postpartum, parenthood, and bereavement. Without further ado, I am so happy to welcome Angelica Quezada. Thank you so much for joining us.
Thank you, Nicole. I am truly humbled by really seeing all the diverse individuals that have joined us, that they've shared in the chat. Please continue sharing on the chat. I'm going to encourage all of you to share in the chat where you're joining us from, your name. If you think of any resources or even just something pops in your head in regards to topics that we're talking, share it in the chat. I always find it really almost like a really positive, beneficial thing of these webinars when we allow ourselves to kind of spread the word of the things and resources that we have so others can use it, whether if we are across the nation or not. In addition, I am going to encourage all of you to please participate in this course through the chat. Share your thoughts, share your comments, and towards the end of the course, I am going to present 2 case studies, and I want to hear from you. I want to hear, based on what you've learned in the past 45 minutes, what can you do to provide support for this individual in this case study? In addition, if there's any questions or if you have any questions, please put them in the question and answer feature that there is in Zoom, or even if you put them on the chat, just a caution, they might get a little lost if you put them in there. So I would encourage you use the Q&A little icon that you see on your screen. Now, before we get started, I do want to acknowledge that many of us at times are impacted either directly or indirectly, personally or professionally, by reproductive loss. So it can be a difficult topic to sit and listen and think about. I am going to encourage you to please listen to your needs. If you need to step out for a moment, if you need to put me on mute, I will not take it personally. Please do so. Just make sure that you are attending to your needs today. Now, today we are here to recognize that reproductive loss can be defined in many different ways. But one of the things that we often don't think about is that 4th trimester after a reproductive loss. Sometimes we focus on the grief, we focus or maybe on the potential, on the hope of future pregnancies, which is great. But we also need to acknowledge all the different changes that are happening in that 4th trimester for somebody who has experienced a reproductive loss. First of all, I do need to just let you all aware that I don't have anything to disclose. And before we jump into this topic, I want to go ahead and think about these 3 main objectives that we want to achieve today. We want to make sure that we understand the frequency of reproductive loss, assess its effects on the patient's postpartum recovery and grief journey, and explore diverse approaches to facilitate emotional healing following a reproductive loss during that 4th trimester and beyond. So, what is a reproductive loss? Before we fully discuss all this, we do really need to have an understanding, a definition of how can we define a reproductive loss in the 4th trimester. So there on your screen, you can see a little bit of a glimpse of how we define it. Reproductive loss includes an array of different types of losses, such as infertility, miscarriage, stillbirth, neonatal loss, abortion, loss of parental rights, adoptions, children born with disabilities, early infant death, and beyond. Sometimes we think of reproductive loss and we narrow it almost to like just infertility, miscarriage, stillbirth, and kind of just stay in that silo. So we need to be able to open up and say, wow, reproductive loss actually includes more than just those type of losses, right? And what is the 4th trimester? I think we're starting to have a more understanding of the needs of the 4th trimester, and we're finally, I think, shining more of a light in those needs. So the 4th trimester can be defined as those 12 weeks after delivery, or even after of a pregnancy loss. As I mentioned, most people don't think of the 4th trimester if there's no baby to take home, right? Or in the case of other types of reproductive losses. Yet the 4th trimester still occurs. You're still going to experience that time frame after the loss or after a delivery, whether if you do have a baby to take home or not. The individual who gave birth or carried that pregnancy will still experience those physical, emotional, societal changes. And it's important that we do focus on providing that support. But then how do we do that? How do we provide a support focused on the 4th trimester, but also focused on providing grief support? So let's start a conversation with getting some statistics about reproductive loss in that 4th trimester. Reproductive loss is much more prevalent than people realize, and many of us are impacted. There are different types of losses that people may experience. So here on the screen, you can see a few different statistics. 1 in 75 pregnancies ends in stillbirth. 1 in 5 pregnancies end in abortion. 33% of the population, that's 1 in 3, were found to have either experienced infertility directly or know of someone who is experiencing infertility. And there are roughly 900,000 visits to the emergency department per year that are early pregnancy loss related. And there are about 20 to 30,000 infant adoptions each year just in the US alone. Now, you might be thinking, well, Angelica, why are we talking about adoption? It's usually something that's celebrated, right? But there are often inherent losses associated with this process, particularly for the birth parents in putting together an adoption plan. But there's also loss for the part of the family who's adopting as well. Maybe they struggled with infertility, or they've struggled with reproductive treatments or other types of reproductive losses, right? So although reproductive loss is so prevalent, many people feel really isolated and alone. There can also be high levels of shame and secrecy, further isolating individuals, especially in that fourth trimester time. This is a time where the individuals sometimes find themselves needing additional support. So if we know that reproductive loss is so prevalent, where we're seeing 1 in 4 pregnancies ending in miscarriage, let's think about the statistics for the fourth trimester care and how these might impact individuals. So about 40% of moms attend their postpartum follow-up visit. Only 40%. Think about that. This visit only usually happens 6 to 8 weeks after postpartum, and that's it. No other follow-up visits unless something really drastic is highlighted in that follow-up visit. There might be no additional follow-ups. Around 53% of pregnancy-related deaths occur up to 1 year after delivery. This just further illustrates the need for postpartum care. In 2022, a journal article titled Prevalence and Predictors of Symptoms of Perinatal Mood and Anxiety Disorders among a sample of urban Black women in the South reported that about 15 to 21% of pregnant and postpartum women experience perinatal mood and anxiety disorders. And the World Health Organization shared that in 2022, 3 out of 10 women and babies did not receive postnatal care in the first days after birth. So what is this telling us? It's telling us that individuals in general during pregnancy and after delivery are not receiving the care and support that they need to thrive in their families, to thrive in their communities and their lives. So remember the statistics we just mentioned about reproductive loss? Now consider an individual who experiences a reproductive loss somewhere or sometime in their pregnancy journey. How often do you think these individuals attend their postpartum visit? How much support are they receiving for their physical, emotional recovery needs during those first 12 weeks after delivery? We often don't think of reproductive loss and the fourth trimester care statistics impacting each other. Now, I do want to share about another study in 2021. This study is titled Maternal Health After Stillbirth, Postpartum Hospital Readmission in California, reported that the rate of postpartum readmission was higher among women who had stillbirths compared with women who had live births, up to 1.5 times greater. With the most common indicators at readmission being uterine infection, pelvic infections or diseases, psychiatric conditions or needs, hyperintensive disorder, and urinary tract infections. So all these numbers, what really they're doing is helping us illustrate the importance of additional monitoring and counseling after pregnancy loss for potential postpartum medical and psychiatric complications. Let's not forget, sometimes whether if we are a nurse or healthcare or maybe mental health, we focus on what's within our scope of practice because that's what we need to do, correct? But we really need to see the whole picture, the whole person, what is going on, what's happening, how can we provide this care? So I have put this quote up on the screen. This is one that we fairly often use in our trainings here at the Institute. And the reason I have it here is because I think it really well illustrates the needs, the importance of highlighting those needs in the fourth trimester without even mentioning the fourth trimester. So it states, perinatal loss has well-documented detrimental effects on the health and well-being of the bereaved parents individually and as a couple. Compared to other types of mourning, like the loss of a parent or a sibling, the loss of a child is associated with a grief experience that is particularly severe and long-lasting and complicated. So yet, individuals who experience reproductive loss are often disenfranchised. Right? Dr. Kenneth Doka, who is a leading expert on grief counseling and therapy, identified this term, disenfranchised grief, to describe a loss that is not openly acknowledged, publicly mourned, or socially supported. Among healthcare professionals and society at large, however, perinatal loss is generally viewed as less traumatic or prolonged experience than the death of an older child or an adult. Perinatal loss has been characterized as ambiguous loss, stemming from the concurrent physical absence of and psychological presence of fetus, baby, or that infant. So therefore, disenfranchisement can be experienced at multiple levels from multiple sources. The inability to hold space to process this grief may lead to potential impacts on mental health, which we will touch base in a few slides. Before we go to that, I want to introduce this concept of the reproductive story, because I think this is going to really help us understand the impact. We all have a reproductive story. And when we begin to write it, it begins at a really early stage of our life as children. Most of the times, we're not conscious about this. And it kind of just starts to write itself. Maybe we're playing with dolls, we're playing with cars. We see the interactions that we have with our family or extended family or within our community. And we start saying things like, when I grow up, I only want to have daughters. Or if you have children or you're around children, you probably hear this often. Oh, when I grow up, my kids don't have to eat their vegetables. That is writing of the reproductive story without maybe such a big highlight or conscious awareness of it. So we start thinking, and as we grow, this story develops and it grows with us. And we might start to think, do I want to have children? Do I not want to have children? How many children do I want? It never ever includes a reproductive loss. It never includes navigating the challenges of a fourth trimester. To further illustrate this, I do want to share just a little bit, a glimpse into my reproductive story to help you paint this picture. So as a young child, I'm the second oldest of 7 children, which means I had a lot of parentified roles. I didn't really think about having children. I actually told myself, I don't think I want children. And if when I grow up and I change my mind, I'll become a foster parent and I'll go ahead and fulfill my parental duties, and I'll love these children and I'll provide them support. And that's it. That was kind of like my story for a very long time. And then I met my husband and things changed. So once I met my husband, once we got married, then I started to think, wait a minute, I do want to have children. Do I want to have children? What would I be like as a mom? Started to reflect on things that happened or experiences in my own childhood, thinking, oh, well, if I do want to have children, if we do have children, I want them to play with sports, play in different sports. I want them to learn about their culture. And I started to have these dreams and visions of what my boys and girls will look like, because I said I want both. I want both boys and girls, and just imagine them playing around during our holidays, during family interactions. We're a Mexican-American family, so we have a very, very large family, and I could see them almost running around playing with cousins and aunts and uncles and all of that. So, and then I find myself expecting my first pregnancy. And oh boy, my reproductive story changed again. My first pregnancy was very, very difficult. There were many, many challenges throughout the entire before conception, during the pregnancy, during delivery, and then after that first or that fourth trimester. I secretly struggled with severe postpartum depression and anxiety. And about 4 months after giving birth to my daughter, I started to seek support from professionals. 1 month later, after starting therapy and all of that, I found myself expecting my second pregnancy. The second pregnancy started to look very much like my first pregnancy. But then at 13 weeks, we lose our child. We experience a miscarriage. I gave birth to my son at an emergency department room, and I went home with very little information. That same week, within that same week after losing my son, I started lactating. With my first child, I struggled and my milk never came in. But with my second pregnancy, I had no baby now, no new baby, no baby from my second pregnancy, but I started lactating. I started facing a lot of these fourth trimester challenges, which I was somewhat aware of because I've already had one pregnancy, but yet they were different. I was lactating, I was parenting, almost 7-month-old by this time now. My body was changing. I still had postpartum bleeding, as well as I was now navigating grief. Fast forward to March 2020, only just a couple of months after my loss, and we find ourselves in the midst of a pandemic. Finding physical and emotional care was not easily accessible. It was put in the back burner. All these items, all these experiences impacted again my reproductive story, leaving me with, do I want to try again? If I do find myself pregnant again, will I be worried the entire time? What if it happens again? There were dreams, there were hopes, there were expectations that did not come into fruition. There was grief and other needs that took priority. So bringing it back to the population that you work with, think about this. By the time most individuals who experience a loss let's say stillbirth or an abortion or termination for medical reasons or a miscarriage or a neonatal loss, by the time they go to their first postpartum visit, 6 to 8 weeks after delivery, those that do go, they have already gone through maybe a vaginal birth, surgery because of an incision because of a cesarean, maybe a DNC, postpartum complications, physical and mental, lactation without a baby to feed, possibly navigating grief on their own, all of these things before they even go to that postpartum visit, if they have one or if they do go. We see that there are many potential impacts of reproductive loss that can occur during that 4th trimester and beyond. People sometimes get stuck and they might find themselves not coping very well, which can lead to some unhealthy behaviors. So there on the screen, you can see some of those potential impacts on mental health. And really, studies indicate a higher incidence of unhealthy behaviors, substance abuse, depression, suicide, or other mental health complications after reproductive loss. In a 2022 research article by Professor of Nursing at St. Martin's University, Nikki Berry, The Trauma of Perinatal Loss, a Scoping Review, she revealed that 25 to 75% of the time, complicated grief can follow a perinatal loss. 30 to 60% of those who experience a reproductive loss meet the criteria for PTSD, and up to 60% of bereaved parents exhibit symptoms of depression, anxiety, and PTSD. So, we're navigating our grief. We're navigating all these possible complications. Remember, don't forget, physical, emotional, and social changes of that 4th trimester, they usually occur almost for everybody that delivers a baby, whether if we take a baby home or not. So we might see this impacts on top of those mental health complications. We've mentioned briefly some of these already that you can see on the screen. Most of those who experience reproductive loss receive little to no information or support on these changes. And it's important, especially for first-time mothers or birthing parents, to get this information, that we spend the time with them to highlight these potential changes, when and where to seek support if needed. Lactation and physical body changes are 2 of the biggest concerns that are normally or usually not addressed. We need to provide psychoeducation on what these physical, emotional, and social changes might be like, and follow with those resources, follow up with some support. It can be really painful and can be really traumatic for an individual who's had a healthy pregnancy, has a delivery, has a baby who is born either stillbirth or maybe spends time in the NICU and dies, to 3 to 5 days later, once they're home, have their milk come in. And if they're first-time mothers, birthing parents, not knowing what to do. What are those expectations? What do I do now? How do I stop lactating? So just as it's important that we provide the information on those physical, emotional, and social changes, it's also important for us to not forget about grief. So I really want you to think about those that you see on the screen. How can we provide information, resources for those who experience a reproductive loss on what to expect in regards to lactation, other health complications, hormonal fluctuations, body changes, and like I mentioned, grief and loss. One way that we can do this, that all of you could do this the very next time that you're supporting someone navigating through their grief after a reproductive loss, is by using the tasks of grieving by Dr. Worden. So Dr. William Worden is a world-renowned psychologist specializing in grief counseling and therapy. He found that rather than stages of grief, there are tasks that are completed throughout the grieving process. There is no order to them. You can often move in and out of the different tasks as you are going through that grieving journey. It is not linear. You do not complete one step and move on to the next, close the door in that one. It doesn't happen like that. And it can often be really messy. There could be some good days or good moments, and some bad days and some bad moments. It can be described more like circles of grief. I always like to describe it as waves in the ocean and kind of illustrate this visual. You know, sometimes when you go to the beach, you see a wave coming in and you're like, oh, I can handle that, right? That's not a big wave. I can handle that. And then it hits you, knocks you off your feet. And you're like, whoa, I was not expecting that. Or it could be the opposite as well. You see this big wave coming in, you're like, there's no possible way I can manage this. I can't handle that wave, that's too big. And by the time that it hits you, it's a very gentle wave by your feet. And you're like, wow, I was able to manage that more than I thought I could. Maybe because I had coping skills, or I had support, or I had resources. So what are these tasks that you see on the screen? Accept the reality of the loss. When someone dies, there's often a sense that it hasn't happened. This task takes time, and it involves intellectual and emotional acceptance. In addition, one must come to terms with the full impact of the loss, which may include a change in relationships, roles, or dreams. Process the pain. Worden acknowledges that each person and each loss will mean working through a range of different emotions: sadness, fear, despair, guilt, shame, relief, many other. When working with individuals who have multiple losses, we need to remember to process each loss individually. A person must acknowledge and talk about these feelings in order to begin to understand and work through them. The danger is denying these feelings and avoiding them, as it could lead to maybe some unhealthy coping behaviors. Adjusting to the world without the disease. You have to adjust to this world without the disease and create a new future. In other words, what does the world look like without that person or that child? After a loss, a person no longer is the same, nor does the world look like the same as it was before. Often, people, when they share stories with us or with others, they'll say, oh, I just wanted to be like it was before. But that's not possible. Here, we could walk along with our patients and have them tell or even write about the reproductive story and how after that loss, one has to rewrite their own reproductive story. We have to make some edits to it. And finding an enduring connection. So this is finding an enduring connection to the person who has died or to the loss. A central part of this task is letting go of the pain as a sole connection to the loss, so we can move forward and continue to engage in a meaningful way with life. Here, individuals work towards allowing thoughts and memories of the loss, yet engaging in things that bring them joy and pleasure, like new experiences or new relationships. Memorializing can be one way that we can support our patients or our clients as they navigate this task. There are many ways to memorialize. It could be journaling, writing letters, planting a tree, through jewelry, letting go of balloons, There's many, many ways. There's no one way to memorialize, and often we can start that guidance with our patients and our clients, but really ultimately it's going to be what feels right for them. By providing them with something tangible, something to hold or experience, can be really powerful in their healing journey. So just to summarize a little bit, some really simple yet profound goals that we can work through when we're supporting somebody who's experienced a loss is to acknowledge that loss. I am so sorry for your loss. I am so sorry for the loss of your baby. To listen with compassion and empathy. To listen to understand. I always like to remind people, we want to listen to understand, not to respond. We're really good at that. Everybody's great at that, to listen to what somebody has to say, to immediately respond. But listen and sit with that compassion and empathy and give it back. Offer options to memorialize if they wish. Maybe they need some help with ideas. Give permission and space to grieve. It's really hard for some of us to even think of the idea of death. So when there's a reproductive loss, we often see that it's very kind of dismissive comments. You can try again, you're so young. Oh, well, at least you have 2 other children at home. Those kind of things could be very dismissive. Instead, giving permission. Provide referrals, resources. This will include resources not just for grief and loss, but also for those needs that we mentioned during the 4th trimester. So really, your role is to provide that compassionate care, to remind individuals and families and couples that you work with that there's no timelines, to normalize their grief. There's no shoulds, no one way of grieving, and to really hold space, to give that permission, which sounds really silly, right? But it's giving that permission to enfranchise grief. We want to go ahead and respond with that compassionate language. So on the screen, you have some very brief, simple examples of things that you can say and things that you can do to support someone. I am so sorry for your loss. You are not alone. Asking about their needs. Reminding them, especially when there's conflicts between couples or family members, because there's this perception that maybe he or she or they are not grieving because they're grieving differently. It's okay. Everybody grieves differently. Offering those resources or referrals. Now, I can probably almost hear some of you say, well, that all sounds great, but we don't have the resources. We don't have the time. We don't have the time to sit with them and maybe provide grief counseling. Or I don't know what to say. What if I make it worse? Right? All these are some potential barriers. And I understand that sometimes we feel like we don't have the time. But really, it is those just key, brief moments where we make a little tiny switch in our language, a tiny little switch in maybe dimming the lights, sitting right next to our patient or a client, giving them the full attention. We'll chart later, we'll add to their notes what we need. We will do that. But having that, eye contact if it's culturally appropriate. One piece of research that I will encourage all of you to read is Dr. Jennifer Butte and Dr. Maria Brand's research article titled Qualitative Assessment of Bad News Delivery Practices During Miscarriage Diagnosis. Here's going to give you some really good specific clues on how to navigate that language. Now, a lot of what Dr. Bude and Dr. Brand talk about is the specific words to utilize. But a big thing that we can do is companion our patients. And you're going to find yourselves maybe in moments where there's these awkward, quote unquote, awkward moments of silence. But guess what? That's part of companioning your patient. Being comfortable with the uncomfortableness of the situation, with the confusion, with the chaos, with the why is this happening? Why is it to me type of situation, type of questions that might arise. We are really great, I think, as a healthcare, mental health society and providers at providing that expert treatment approach, which we still need to do. But now we need to add that companion piece. So what does that look like? How can I do this? So I already mentioned one. Allow for that awkward silence, sitting next to your patient, listening for understanding, showing that compassion through actions in the language that you're using. Offer choices, even if it seems sometimes insignificant, like, would you like for me to put your pressure cuff on your right or your left arm? Right? Sometimes during a reproductive loss and navigating that fourth trimester, everything seems like out of my control. Everything is happening to me. So if you can, whenever possible, give choices, give options, and mirror your patient's language. This is really going to help us to be present and show and demonstrate some of that empathy and compassionate language. So an example, if your patient or your client is referring to their pregnancy as a pregnancy, say pregnancy, baby, say baby. Little Johnny, ask if it's okay to refer to little Johnny as little Johnny. Mirror that language. One other big aspect that makes a big impact is to be aware of the cultural and spiritual needs of our patients and clients that we work with. So a very simple way that we can do this is by asking, is there anything about your cultural or spiritual needs that I would need to know about as I provide care for you today? And I'm going to encourage all of you present today, all 49 plus of you, think of a question of how you can reframe this question, include it as you're providing care in your daily providing care, just as we assess for suicidal ideation or any other needs. Ask about the cultural, spiritual needs. We want to make sure that our patient is the expert, so we're asking for that communication. We want to make sure that we are also providing that communication in our patient's preferred language. You want to make sure that we are not making any assumptions based on race, ethnicity, or language, and assess for desired memorialization, rituals, or disposition of body. Remember, each individual experience is going to be so unique. But when we go that extra step of really truly seeing this person as a whole person and acknowledging that there are going to be these other parts or components that are really important probably for their life, and if we can incorporate them, do so. Don't make any promises, but ask, inquire, and if you can, incorporate them. This last piece before we go into the case studies is really about ongoing support. So we quickly went through a few different things that we can do. We talked about the tasks of grieving. We talked about some of those goals for providing grief support. We talked about the reproductive story, talked about being really aware of the physical, emotional, social needs that happen during that fourth trimester while navigating grief as well. So think, how can you incorporate this ongoing support? Will that be maybe setting up this individual with a follow-up grief and physical or practical interventions? Will that be providing printed materials for lactation? Will that be providing community resources or engaging them in some type of social support? So again, this is another aspect of what I would encourage you, make a couple notes within your practice. What are things that you are already doing? Because it's going to make it much easier if you do. What are things that you are already doing that you can maybe add an extra step without making it seem like we're adding too much, or modify so that it fulfills these needs of grief, but also that fourth trimester needs. All right. So I've mentioned in the very beginning that we were going to have 2 case studies. And this is really where I'm going to ask from all of you to input in the chat to try to respond to some of these questions. So we're going to have case study number 1. This is going to be with Anna. And I want you to think about the following questions. How do you assess for the experience of reproductive loss? What would you say to acknowledge those losses or that loss? How might you assess for any coping skills? And how might you assist in the grieving process, considering the needs of the 4th trimester? So let me read this case study to all of you. Anna is a 38-year-old G3P1. So for those who might not know, G is gravida, number of pregnancies. P is parity. There's a number of pregnancies gone past the 24-week mark or gestation. So Anna, 38 years old, G3P1, who presents to the hospital after experiencing a gush of blood when she bent over to pick up something off the floor. She said she has been continuously bleeding and passing clots. She reported her last pregnancy ended in a stillbirth 2 years ago due to an umbilical cord incident. She has been crying continuously and has family with her. Tests indicate the pregnancy is not viable. So what are some of the things that you would do to provide the support to Anna? And you can modify it however you need, whether if you are in a hospital setting, in a clinic setting, maybe in mental health type of provider, or you're a community leader. How could you provide support to Anna? I would love to see some comments there in the chat. Think about the tasks of grieving. Think about the reproductive story. Think about the past losses she's experienced. Sorry for your loss and previous losses, Chantel. Yeah, absolutely. Right. We also want to remind ourselves that we want to acknowledge past losses, current losses, and that each loss is its own individual loss. Right? Thank you for that, Chantel. What else could we do? So as you put things there in the chat, some of the things that we can definitely do is to go ahead and accompany Anna in her loss, provide resources, not just for her, but for her family. Ask her if she received any support for her stillbirth 2 years ago. And if she did receive support, was it helpful? Was it not helpful? Did she memorialize that loss? Currently in the present, what is she feeling with the news that she just received? She might say, I'm scared, I'm terrified. Why me again? My body can't I can't carry a pregnancy. I feel like a failure. We want to make sure that we are acknowledging and validating her feelings, her thoughts, but also reminding her that she is not a failure. I see a few more things in the chat. Let's see if I can read those. Oh. Assess if I already established with a patient prior to this event. I would provide education about what is happening first and explain what we think is happening medically, then provide an apology and ask what she might need in this moment. Absolutely. I can imagine that this is difficult, but have you been able to mourn the previous pregnancy losses? Does she have a child address that she still, I'm sorry, did not understand. Does she have a child address that child needs? Or does she have a child maybe at home? Is that what you're saying? I think that's what you're referring to. Memorialization. Yes, we want to always make sure that we are meeting with our patient where they're at, right? Providing the information, assessing to see for understanding, providing that acknowledgement of the prior losses, acknowledging this current loss, what coping skills maybe helped in the past that she can utilize again, but also establishing support for the now. There's family there. Could any of those family members truly provide her some additional support? Or maybe they're also not in a good place right now where they need their own additional support. Think about this second case study. Lupe is a 42-year-old G5P0 who presents to the clinic alone at 18 weeks pregnant. She reports that she's experiencing severe low back pain and it's spotty. She also reports that she is single and became pregnant via IVF. A bedside ultrasound revealed no fetal heart tones or movement. She's pale and not speaking. She's stable and her first language is Spanish. So what would you do here? Same questions. How do you assess? How do you provide support? How would you address her cultural, spiritual needs? How can you assist her? Maybe if she does go home, let's say she goes home and she has a miscarriage. The miscarriage happens at home. She delivers at home. What kind of resources can you provide her to go home for when that happens? Consider the needs that she's going to have afterwards. So she's 18 weeks pregnant. She can very well lactate 3 to 5 days later after delivery. She mentioned that her first language is Spanish. When there is a second language, I always encourage, think about what's the native language. That individual may say, I'm okay with speaking English. I understand it fairly well. But I always say, if you do have those resources printed and that information in that second language, which is their primary language, their native language, give them to them. So for Lupe, I will give her her resources in Spanish and I will give her her resources in English. Because she might very well jump between one and the other to kind of get an understanding of what she can really get in regards to support. She's experienced multiple losses. She's presenting alone. Can I accompany her? Sit with her, even if it's in silence, for a little bit. I see a few things in the chat. Get an interpreter. Ask for family support to be present with her. Yes, if you can, call a social worker or call a family member that maybe will be able to come in with her. Ask her what she needs in this moment. Make sure she understands what is happening to her body. And I see using interpreter, giving resources in case of lactation, culturally appropriate mental health support. Help create an ongoing home plan for managing pain after birth care, social emotional support, follow-up medical care, etc. So yes, so all those different things that we saw on this slide, we want to kind of address a little bit of all of that, and we want to address the grief. Asking if there's any support when she goes home. Absolutely. So creating even a very simple yet efficient plan can incorporate what is emotional support, what practical support, social support, and informational support does this person have or need, and how can they access it? So my last comment for this is I would encourage you to take these, continue to think about them, but also if you're providing this type of care, that you are providing some self-care to yourself. We want to make sure that before we are doing the best that we can as a care provider, we're also looking at our needs and fulfilling those needs. And if you need more additional support on that, or resources or courses, we do have a full course through the Institute titled Invigorating Compassion, and another one titled Grieving Well that you can definitely access through our websites. And even just acknowledging that this is a difficult topic and getting that support from your colleagues. Briefly, I do have, since I know there's going to be a recording available, these are just some brief support resources that you can access. So these are specifically for grief. These are specifically for more of those fourth trimester needs, but yet PSI is doing a great job right now with incorporating grief support groups and acknowledging that this is something that happens at the same time. We can't separate it. So PSI is a really great source to kind of address, a great place to start to address all these needs. If you're in California, if you're in San Diego, Postpartum Health Alliance is another wonderful nonprofit organization that also addresses all of these needs. So I've been asked to go back to this slide, so I'm gonna leave it there for a second if people want to take a screenshot or anything like that. But I want to thank all of you for being here. And Nicole, I don't know if we have maybe a couple minutes to address any questions.
Sure, we have a couple of questions. A lot of them were about the book and the article that you mentioned. And I knew you had resources at the end, but I don't know if you can share that, or you can even email it to me and then I can send it. That was one.
Mm-hmm.
So is it listed here, the article or the book that you
Yes.
mentioned? Okay.
It is listed. It is listed here, so you can feel free to take a screenshot. And I believe that is open to the public, so anybody could just Google it and you'll be able to get it or access it, the link.
Wonderful. And then I'm going to go to the two questions for those of you who can stay on. So Julia was asking, how does the risk and likelihood of complicated grief or PTSD, other mental health risks across racial demographics?
Well, wonderful question. So this is the thing. As we do our literature reviews, unfortunately, we find ourselves that there's lack of research. I want to say, I think I found 2 articles that addressed LGBTQI plus community. 2. That's kind of ridiculous. So when we're talking about African-American, Mexican-American, or other minorities, there's really almost nothing. We're starting to finally see researchers do some research, and we like to highlight as much as we can through our research reveal series that we do every quarter. But unfortunately, Julia, we don't have a concrete answer because we don't have the research. Yeah.
And then her follow-up question, and I know there's also one from Sarah back in the chat, which I'll go back to. But Julia also asked, what do you suggest for intakes with perinatal clients and asking about reproductive loss? Is it more helpful to understand the impact of the loss, symptoms and timeline, or wait to further in the therapeutic relationship to ask these questions?
Great question, Julia. We want to ask from the beginning. This is something we talk about a lot in our mental health course, our Foundation mental health course. Incorporate it in your intake. Go back, Julia, today, revisit your intake questions that you have and see what kind of questions do you have in there that talk about reproductive loss. So for example, simple questions that you can have in there is, are there any other additional pregnancies? Have you had any type of reproductive losses? I've seen some intakes that have it very specifically labeled like stillbirth, miscarriage, abortion, termination for medical reason. Of course, with today's environment, sometimes we need to adjust our intake questionnaires and how we do that. But go back to your intake really and think, do I have any questions that ask or assess any type of reproductive losses? If the answer is no, incorporate one of those in there.
Thank you. And then Sarah asked, acknowledge the losses, give her room. Oh, I'm sorry, I'm reading the wrong thing because I know Sarah said that. She was asking, okay, here it is. Can you tell me about any cultural, spiritual preferences you have for this appointment, procedure, delivery?
Oh, that's a great way to reframe it. I think Sarah, what she was doing is saying another way that we can ask for those cultural and spiritual needs. Right. And that's a great place to start. Really take that question and whichever you feel comfortable in, whichever way, whatever words you feel comfortable using, but ask, assess for those cultural and spiritual needs. Again, don't make promises because you might not be able to fulfill them. But if there's things that you can do, incorporate them.
Sarah's letting me know that was a response to maybe reframing. Sorry, Sarah, I still thought it was great. Also, we have Veronica who's saying, my friend and RN lost a pregnancy 4 months after finding out the sex of her baby. 3 months later, the 19-month-old was, she said, hit by a car. He didn't make it. She is in her late 30s and is afraid she'll never be a mother again. She's connected to a religious community, but culture says some insensitive things, like at least you were their mom. What else, what can I say to help bring comfort?
I am very sorry, Veronica, for your friend and the losses experienced. I think, Veronica, what you can definitely do is, as one of the things we mentioned, is acknowledge each of these losses because each of them are very unique. Unfortunately, we cannot fully protect those we love from what society, other individuals are going to say, right? But we can mitigate some of that impact by being present with them, by letting them know that we are a safe place for them to share. And probably, Veronica, your friend might have pictures, sonograms, ultrasounds, pictures of her 19-month-old that maybe she's not sharing as often, or that people don't even ask about them anymore. And one of the most common things that I've seen with the patients that I work with in private practice and here through the Institute is that I fear that my child is going to be forgotten. Nobody ever mentions them. Nobody says their name anymore. I don't have a chance to talk about them because I fear that people are going to criticize me. You could be that safe space for her.
Thank you. Thank you so much. Angelica, Quezada, I just really am so grateful for learning about the Institute of Reproductive Grief Care. We know in our community that this is needed and we need to talk more about it. And I just really appreciate being able to have you at the Maternal Infant Health Series for Wayside Recovery Center, the wisdom, the resources you provided. And then, Angelica, are we able to share the slides? Some people also wanted to know if we would be able to share the slides.
Yeah, we can share the slides.
Okay.
I've also included my email on the chat, and
Thank you.
I am more than happy to respond, email, text, calls, in whichever way that I can get in contact with all of you.
Well, thank you so much. So today, everyone, we are so grateful that we were able to have this talk, reproductive grief care in the 4th trimester, provided by SAMHSA and Minnesota Department of Human Services. Next month, actually in a couple of weeks, we will also have Dr. Jess Daigle, who will be talking around infant care and maternal health. Thank you, everyone, and have a great afternoon.
Thank you.